بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد.
Bismillahirrahmanirrahim. Assalamu alaikum. On behalf of Pakistan Endocrine Society, I welcome you all to today's webinar on clinical pituitary management guidelines on pituitary tumors. I am Dr. Paris Imran and I'm working as an assistant professor endocrinology at JSMU JPMC Karachi. These guidelines are very comprehensively developed and recently published with immense contributions of President Pakistan Endocrine Society and various other scientific and executive members of Pakistan Endocrine Society. And these are specially designed for resource limited settings such as that of ours. So series of webinars have already been conducted on these guidelines. And today we are going to discuss Cushing's disease guidelines. And to discuss these guidelines, we have esteemed panel of experts with us. Our first panel of experts with us is Professor Najmul Islam, who is a professor of medicine and consultant endocrinologist at Aga Khan University Hospital, one of the founding members of Pakistan Endocrine Society and past president of Pakistan Endocrine Society. Welcome, sir. Our next panel of experts is current president of Pakistan Endocrine Society, Dr. Aisha Sheikh, who is also working as a consultant endocrinologist at Aga Khan University Hospital, Karachi. Welcome, madam. So our presenter for today's session is Dr. Waqas Shafiq, who is also one of the authors of these guidelines and currently working as a consultant endocrinologist at Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore. He is also one of the executive members of Pakistan Endocrine Society. Welcome, sir. So we'll formally start our session. And to begin our session, we have pre-test poll. I would request all the participants to please attempt these questions, and we will discuss these questions at the end of the presentation. Okay, so I will read these scenarios for you. Case number one, clinical presentation is that of 40 years old lady with 6 months history of diet control, diabetes mellitus, hypertension for 7 years, chronic renal impairment, presented with weight gain, easy fatigability, oligomenorrhea, and impairment of concentration and memory. Next, please. So how to investigate? She's on medications such as omeprazole, amlodipine, atorvastatin, aspirin, and escitalopram. On examination, she has truncal obesity, supraclavicular fullness, thin arms and leg skin, lax skin, and multiple skin stria. So how will you investigate this patient? So I hope you can see on your screens 5 options. Please select one of the option and submit. Option number 1 is MRI pituitary. Option 2 is check ACTH and cortisol. Third option is 24-hour urinary cortisol. High dose dexamethasone suppression test. And last one is CT chest, abdomen and pelvis. Now we'll move to case number 2. Case number 2 is that of 36 years old lady referred to an endocrine clinic for evaluation of uncontrolled hypertension and incidental adrenal nodule. She had raised blood pressure while undergoing CT-guided biopsy for hepatic mass. She presented with generalized abdominal pain for 9 months. On examination, her BP is 180 by 100 millimeters of mercury. Pulse is 92 beats per minute. Facial plethora is present. She's having proximal myopathy and purple stria. On investigation, she had microcytic anemia with HB of 6.9. And electrolyte sodium was 141, potassium 3.06. LFTs were normal. So how will you investigate? Again, choose any one of the options and submit, please. Option number 1 is CT adrenal. Option 2 is check ACTH and cortisol. Third option is 24-hour urinary cortisol. Fourth is check ACTH. And last one is CT chest, abdomen and pelvis. Quickly select option so that we can move to a next question. Okay, moving to case number 3. So what should be the next step? This is the continuity of the previous scenario. So what should be the next step? Can just go through case 2. Can you please go back to the previous slide? Let the viewers go through the case scenario number 2 again, and so that they are able to answer number 3. Okay, so case number 3 is 40 years old lady presented with history of diabetes for the last 15 years and hypertension. She has a BMI of 38 kilograms per meter square and trying to lose weight for the last 10 years. On examination, she got central obesity, facial and supraclavicular fullness. So what should be the next step? Number 1, a 24-hour urinary cortisol. Option number 2, MRI pituitary. Option 3, low probability of Cushing's disease, so no investigation for Cushing's syndrome needed further. And option 4 is overnight dexamethasone suppression test. Quickly select one option, then we'll head to the presentation. And we will discuss these answers at the end of the presentation. If you have any questions, you can just write them down in the question and answer window and we'll address them. So now we'll start our presentation and I'll request Dr. Waqas Shafiq to please start. Over to you, sir.
Thank you very much, Dr. Paras. Let me share the presentation first. Assalamu alaikum, everyone. So my name is Dr. Waqas Shafiq, and I'm a consultant endocrinologist at Shaukat Khana Memorial Cancer Hospital and Research Center. As Paras mentioned earlier, so the main aim of this session today is to disseminate the guidelines which we prepared, the Pakistan Endocrine Society and Pakistan Society of Neuro-Oncology worked together and made a guidelines. This is the whole pituitary adenoma management, and this is we specifically made for countries like us where we have limited resources. So that's what we actually when we make these guidelines, we make sure that those guidelines are applicable to us. So let's see what is Cushing syndrome. So Cushing syndrome is caused by chronic inappropriate exposure to excessive circulating free glucocorticoid. This is associated with significant morbidity and mortality. The most common cause of Cushing is use of supraphysiological dose of exogenous glucocorticoid, which we call it iatrogenic Cushing. When we see the patient, you will find patients are taking steroid either in the form of tablets. There will be few who will be using the creams, either they are creams for skin creams or any other preparations. You can see people are getting steroid injections, either intramuscular injections. Few people will be getting the injection in the joints. So it is the most important thing is to take a detailed history and look at all the causes. And also especially in countries like us, the homeopathic medicine, the Hakim medicine, and over-the-counter medication, there's so many medications which contain steroids that even we don't know how many of those contain the steroid. So it is very, very important to take the history of exogenous glucocorticoid, because still that is going to be the most common cause of Cushing syndrome, which means a presentation. When we talk about endogenous Cushing, which means that the body is producing the excess cortisol, then traditionally it is divided into two varieties. One is ACTH dependent and one is ACTH independent. ACTH dependent Cushing account for about 80 to 85% of the cases. So if you look at all the endogenous Cushing causes, ACTH dependent account for 80 to 85%. Whereas when we look at ACTH independent, they are due to autonomous cortisol production from adrenal sources. They account for about 15%. So if you look at this this chart or this table, which was published in 2006, you can see here, as we talked about, that ACTH dependent is the most common, and among that, Cushing disease, which is pituitary related, account for 70%, ectopic ACTH account for 10%. And similarly, when we talk about ACTH independent, then adrenal adenoma account for 10% and 5% adrenal carcinoma, and there are a few others rare causes. Now, endogenous Cushing is a rare entity. The reported incidence of pituitary ACTH dependent Cushing, which account for 70% of the endogenous Cushing, is between 3 to 6 per million per year. And that's why in our guidelines, again, we put a special emphasis that a detailed clinical history should be taken to exclude the use of exogenous glucocorticoid, including topical or inhaled corticosteroid, because if we have not excluded that, then later on we will find it's very difficult, because you will end up investigating a lot and then you will not be able to find what is the cause of it. So when we talk about the diagnostic overviews, so first of all, we should have a strong clinical suspicion for Cushing syndrome. Only then we should go for further investigation in a stepwise manner. So once we have a clinician have a strong suspicion that it is Cushing syndrome, endogenous Cushing syndrome, then we confirm it by the test, and then we go to find the cause, the underlying cause. It is very, very important not to proceed to step 2 without completing step 1. We regularly seeing patient where the physician thought that this patient might have a Cushing syndrome, and rather than confirming it by biochemical test, they do the MRI scans, and this create more and more confusion, because you might end up finding incidentaloma. So for endocrinologists, the most important thing for endocrinology is that you confirm biochemically before proceeding for any further investigation. In endocrine, the training is that you have to confirm biochemically, only then go for any imaging. And the biggest mistake people make is that they straight away go for imaging or looking for the cause rather than actually confirming what they are seeing. So that's why it's very important. And as we talk about, you will understand why it is important. So first, you have seen the MCQs as well, and there was a talk about clinical suspicion. So the most discriminating clinical feature for cystic fibrosis, Cushing syndrome, are facial plethora, proximal myopathy, skin thinning, cutaneous stria, red to purple, and more than 1 centimeter, excessive bruising. Similarly, in children where there is a weight gain with reduced height percentile is also very suggestive of Cushing syndrome. Similarly, a young patient with a combination of hypertension, diabetes, or new onset osteoporosis also warrant consideration of Cushing syndrome. There are several features which are commonly described in Cushing syndrome, such as central adiposity, facial and supraclavicular fullness, hirsutism, acne, peripheral edema, but these are less specific. There is no single feature which should prompt for consideration of the diagnosis for Cushing. However, it is a combination of the feature that is important. Even if they are very mild, that should prompt you for a diagnostic workup. However, a routine screening for Cushing, for a high-risk population, for example, is screening everyone with high BMI, with type 2 diabetes is not recommended at all, because because when we do the investigation, every test has multiple pitfalls, and then you end up in that trap. So the most important is that there is a clinical suspicious. If your pre-test probability is good, only then you go for investigation. So when we talked about, our first step was that clinical suspicion. Now the second step is to confirm that there is endogenous hypercortisolism. And how we can do that? In patients where we suspect, we do 24-hour urinary-free cortisol, 2 measurement, with at least one of the below tests, which could be overnight 1 milligram dexamethasone suppression test, low-dose dexamethasone suppression test, or late-night salivary cortisol, 2 measurements. Let's briefly talk about all these tests briefly, so we can know how these tests can be performed. And as I mentioned, all of these tests have certain limitation, and we need to know those limitations before doing the test. So first, correct method, because you will surprised to find that a lot of people even don't know how to collect the 24-hour urinary cortisol. So it's important that the physician know about it and they inform the patient how to collect it. So the correct method for 24-hour sample is to start collecting urine in the morning by discarding the first void and collecting all urine for the next 24 hours, including the next morning first void. Patient should avoid excessive drinking of water during the urine collection, as high urine volume can result in falsely high 24-hour urine-free cortisol. So they should drink normally, as they normally do. Now, as I say, every test have the limitation. So false positive urinary-free cortisol can be seen in many conditions like depression, obesity, anxiety, alcoholism. And that's why we say it is important to have the high pre-test probability. Because if we start investigating or doing the urinary-free cortisol for everyone who got a high BMI or depression or diabetes, then we will end up these false positive tests, and then they can create lot of investigation. US urinary-free cortisol can be falsely negative in mild Cushing syndrome. Therefore, 2 or more 24-hour urinary-free collection are recommended. Similarly, impaired renal function may reduce the urinary-free cortisol in patients with EGFR less than 60. And the sensitivity of this test greatly reduced in patients with low EGFR. Now, the second test is salivary, a late night salivary cortisol. Salivary cortisol is in equilibrium with unbound plasma cortisol. It is independent of salivary flow rate and is stable in both room and refrigerated temperature. It is it can be performed at home, and it's a non-invasive test. It is not available in Pakistan yet. So, but hopefully in the future we will have that, and it's a very convenient test. Now, the next is dexamethasone suppression test. It actually highlights the impaired feedback mechanism of hypothalamic pituitary axis, which is the hallmark of Cushing. The overnight dexamethasone 1 milligram and 48-hour dexamethasone are widely used in conjunction with urinary free. So you can see here, it's a method. So you give overnight dexamethasone, you give 1 milligram at 11 p.m. And you measure the cortisol at 8 or 9, or you give the 1 milligram at 12, and then you check the cortisol at 9. Similarly, when we do the 48-hour low dose dexamethasone suppression test, is 0.5 milligram every 6 hours for 48 hours, and then you give the last dose at 3 a.m. and measure cortisol at 9 a.m. It also has some limitation. It can be affected by if the patients are not taking the dexamethasone properly, or they have malabsorption, or they are taking medication which are enzyme inducers like rifampicin, phenytoin, phenobarbital, alcohol. That can result in increased clearance, thus reducing dexamethasone suppression levels. Similarly, people with liver or renal disease may lead to decreased clearance of dexamethasone, and hence it can lead to the raised plasma level. Now, there is people which have cyclic Cushing. If we talk about these group, now cyclicity might be revealed by doing multiple measurement of 24-hour urinary-free cortisol or bedtime salivary cortisol. Similarly, where people who got a renal failure, then dexamethasone suppression test may be a better choice, as urinary-free cortisol can be falsely negative. So we talked about confirming. So clinical suspicion, then we confirm the diagnosis. Now we're going to find the cause. What is the cause? So once we confirm that it is endogenous hypercortisolism, then the next step is to find out either it is ACTH dependent or independent. And this can be done by measuring fasting plasma corticotrophin, which is ACTH, on 2 occasions. It is crucial. So this can, as I say, and then this test need to be done. We talk to the lab, because this test, when it's done, it straight away need to go to the lab. So the test doesn't get affected. Now, let's talk about ACTH independent Cushing, as it is brief, and then we will go to the ACTH dependent Cushing. So when we talk about ACTH independent Cushing, again, it is crucial to take a thorough history to exclude endogenous glucocorticoid intake. And if we have ACTH independent Cushing, which means that your ACTH is not raised, If it's confirmed, then the next step is to do the cross-sectional imaging of adrenal. As we mentioned in that chart, there is a 15% where it is coming from adrenal. So this will end up in that group. So now let's go to a main group, which is ACTH dependent, which constitute 85% of the causes. Now, the main differential here is either this Cushing syndrome is coming from pituitary or either it's coming from non-pituitary causes. When we talk about non-pituitary, it's mainly we're talking about ectopic Cushing. Now, if the ACTH is high and we label it as ACTH dependent, then the first thing to do is to do the MRI scan. Now, as I mentioned earlier, the biggest mistake some people do is that they have not confirmed the diagnosis. They're not sure either someone got a Cushing or not, but they end up doing the MRI scan. So important here is that there is a 10% chance of finding pituitary incidentaloma in the normal population. And as a result, if you don't confirm it, then you will end up this trap, because this incidentaloma is probably not causing any problem. But once you confirmed it, then there is the importance of doing the MRI scan, because now if you find something, you know what you are seeing. So in ACTH dependent Cushing, if MRI show a pituitary microadenoma more than 6 mm, we should consider surgical excision, because we have confirmed it biochemically. The patient got a clinical feature, we got a relevant MRI finding, now we can go for surgery. However, unfortunately, a lot of the time with the Cushing, you will not find a microadenoma more than 6 mm. Cushing is one of the most difficult endocrine conditions, and it's rarely simple. So in patients where we don't have a clear evidence of pituitary adenoma, now the production of excess pituitary ACTH can be confirmed with inferior petrosal vein sampling. This test is a specialized test. It is associated with significant morbidity, and this test should be conducted only in the expert center. You can't do it in every center. The procedure, this actually include the placement of catheter into the inferior petrosal venous sinuses, which drain the pituitary. So the inferior petrosal sinus ACTH level are compared with the peripheral level simultaneously before and after administration of CRH or desmopressin. CRH is not available in Pakistan, so with the desmopressin, a basal ratio central to peripheral more than 2 or a post-stimulation of more than 3 is a diagnostic of ACTH. The sensitivity and specificity of this test is 94%. However, as I mentioned, there is only very limited center which do this test. So if it is not available or if your test is unsuccessful, then the following tests are recommended to distinguish pituitary from the non-pituitary sources. Here, we can do the desmopressin or CRH stimulation test or high-dose dexamethasone suppression test. Let's briefly touch how they work. So CRH is used to differentiate pituitary origin ACTH dependent from ectopic ACTH secreting tumor. ACTH producing adenoma tend to be express CRH receptor, and thus they respond to CRH with excess ACTH production, as opposed to ectopic ACTH tumor, which exhibit minimal response to CRH. Now, the CRH is not available in Pakistan. Desmopressin stimulate ACTH secretion similar to that of CRH, and this can be used for this test. The next test is high-dose dexamethasone suppression test. We talked about low dose, we talked about overnight. So this is high dose where it helps us in differentiating either it's pituitary or either it's ectopic. So in high dose, instead of 0.5, we give 2 milligram of dexamethasone every 6 hours for 48 hours. And similarly, there is a test where we give an overnight test where we give a single dose, 8 milligram, is given at 11 o'clock, and serum cortisol is measured at 8 or 9 o'clock. So Any of these tests can be done. It still count as high dose dexamethasone suppression test. The principle is that the high dose dexamethasone suppression is that the overproduction of ACTH observed in ACTH producing pituitary tumor, but not in ectopic. They can undergo partial or complete suppression by a high dose. So if the cause is pituitary, then there is a high likely that there will be a partial or complete suppression of cortisol, whereas in ectopic, you will not see that. Now, if we found that it is not from the pituitary, then we should consider either, because here we are looking for either there is any ectopic. So when we talk about ectopic, which means that the ACTH is coming out from some other tumor, so we may consider doing a CT scan, MRI scan, PET scan. In that we can consider a DOTA scan, because these are neuroendocrine tumors. Mostly the neuroendocrine tumors secrete this, and you can see them better because they are well differentiated. You can see better in DOTA scan rather than in the FDG. So these are the modalities of PET scan. So DOTA scan is better in this scenario. Now, we talked about who to consider for investigation, how we investigate, how we can define what is the source. Now, let's come to the treatment. So here we are talking about Cushing disease, which means that the disease, the excess cortisol is coming from the pituitary. If we find that adenoma is there, or either we confirm it by other method, then the transphenoidal resection of pituitary adenoma by experienced pituitary surgeon is the first line. The most important part here is experienced pituitary surgeon. So it's very, very important to know your surgeons, and the success of the pituitary tumor depend upon how good your surgeon is. So this is the most important factor in the treatment. In this guideline, we talked about the perioperative care, which you can see in the guidelines. I will briefly touch. The stress dose perioperative glucocorticoid is required in patients which are taking adrenal blockage therapy, which I will mention in the next slide. To avoid adrenal crisis, if patient is not taking adrenal blockage, routine pre-therapy, pre-surgery glucocorticoid is not needed. However, to avoid the symptom of acute steroid withdrawal, steroids are given for 1 to 3 days post-surgery, either in the form of dexamethasone every 6 hours for 24 hours, or hydrocortisone 50 milligram every 6 hours for 24 hours. Then we assess the remission after surgery. We stop the glucocorticoid for 24 hours before serum cortisol can be measured. During this period, the patient must be carefully monitored for adrenal insufficiency. Serum cortisol must be checked, and if the morning cortisol is more than 9, then glucocorticoid is not required. However, if it's less than 9, then we should continue giving this patient the steroid and then retest it at later stage. With any pituitary surgery, the first 2 week sodium level should be measured regularly, and if your patient come with any confusions, and well, make sure we check the sodium level. It's very, very important. So in this guideline, we touched about the remission. So remission is defined as morning cortisol less than 5, or urinary free cortisol less than the normal range within 1 week of selective tumor resection. We talked about the surgical management. Now we will briefly touch the medical management. So when we talk about medical management is used for people who, while preparation for surgery, there are people who are not willing for surgery, or they are unfit for surgery, or there are patients where we give the medical treatment post radiotherapy to control the symptom of hypercortisolism while waiting for the radiation to take the effect, which can take some years. So during that time, medical management can be used. Similarly, if you're treating ectopic ACTH, that's where you have to go for medical management. And in patients with acute and life-threatening hypercortisolism complications such as sepsis, severe hyperglycemia, uncontrolled hypertension, heart failure, intractable hypokalemia, and psychosis, medical management can be given to stabilize the patient before you can go for a definitive treatment. Now, when we talk about medical management, now we have agents like ketoconazole. There are other agents which are not available in Pakistan, but internationally they are used. They are like metrypon, acylodrosette, and mitotain. They inhibit the synthesis and secretion of cortisol. So these agents can be used. In Pakistan, ketoconazole is only available. It can lead to a greater than 50% drop in urinary free cortisol in 75% of 200 patients, along with clinical improvement in hypertension, diabetes, and hyperkalemia in one of the study. The only issue with ketoconazole, it's very effective, but we have to monitor the liver function, and it can be hepatotoxic. So it's important when we are starting what we need to monitor, we need to know about it, and this is all we mention in our guidelines. So if anybody want to get a bit more detail, they can read the detail of the guidelines, and you can find that in detail. Other medical treatment such as somatostatin receptor ligands, dopamine agonist, are ACTH-directed agent which decrease pituitary ACTH production. Cabergoline can be used in milder form. Similarly, pasireotide, it's not available in Pakistan. That's another somatostatin analog that bind to somatostatin receptor and then block the release of ACTH from corticotroph. They can be used as well. They're not available in Pakistan currently. Mifepristone, a glucocorticoid receptor antagonist, is used for the treatment of patients who have Cushing syndrome, as well as diabetes or glucose tolerance, and they're not surgical candidate, and that is available in Pakistan. Now, we talked about the treatment, where we talked about the medical treatment, the surgical treatment. Now we're going to talk about the follow-up. Regarding the radiation treatment, we have detail about that in our guidelines as well. I will briefly touch it in the end slide. So long term, we follow these patients need lifelong surveillance for recurrence with at least 6 to 12 monthly assessments for at least 5 years, and then we can go a bit less frequently. The monitoring can be considered earlier if patient report any reappearance of the symptom, then we need to see them early. Re-evaluation should include 24-hour urinary cortisol, overnight dexamethasone suppression test, or late night salivary cortisol. Now, these patients should be monitored for bone health because high cortisol can result in osteoporosis. These patients with even they have controlled Cushing, they continue to have high risk for cardiovascular disease, secondary to insulin-resistant obesity and dyslipidemia. So we need to address these risk factors accordingly. Similarly, throughout the disease management course, psychological intervention should be offered because these people they do have can have a lot of psychological issues with the hormone axis, because of the nature of the disease and the axis steroids, and also the challenges or the difficulties which the patient feel during the diagnosis, during the treatment, and then the follow-ups. Now, for people where there is a persistent disease, repeat surgery can be considered. We can consider the pituitary gland radiation. We can consider medical therapy. It's all depend upon a detailed discussion in the multidisciplinary meeting and look at what treatment is better for the patient, and having a detailed discussion with the patient and then come up with a conclusion. Adrenalectomy, which is either a medical or surgical, they may be used in conjunction with pituitary irradiation in rare incidents where the disease is quite significant. But that's, as I say, this is something which each patient need to be discussed and look at what's the best treatment option specifically to what is available in Pakistan. That's my talk. Sorry, it was a quite detailed. So it was not an interactive session because of the nature of the presentation, but I'm happy to take the question if there is any. Thank you very much.
Thank you so much, Dr. Waqas, for such an eloquent presentation. And I must say you have explained with such a great clarity and concisely. This topic is already very complex. Thank you so much. So if you have any questions, please write them down in the question and answer chat box. And now we will head towards the post-test poll, and we will compare the results at the end of the panel discussion. So I will again request participants to please attempt these questions. So quickly go through this question and pick up one option. Let's head to question number 2. I'm sure all of you can see options of question number 2 now. Quickly pick up option. So we have final question on screen. Please go through it and again pick up an option. Okay, now I will request our esteemed panel of experts to give their valuable comments. First of all, I will request Professor Najmal Islam to share his valuable comments and give his experience on the diagnosis and management of Cushing's disease. Please, sir.
Thank you, Paris, for inviting me for being in the expert panel on this topic. First of all, let me tell those who are sitting in as an audience that we spend many months, really multiple meetings to come up with these pituitary adenoma guidelines. And so a lot of effort has gone in. And we have taken some experts' advice from the developed world as well on this topic. So, but coming on to the topic, today's topic of Cushing's syndrome. Waqas has really given a very good overview of the subject in a lot of detail. It is a topic, Cushing's, which is not easy to investigate and neither easy to manage. It can be confusing in best of the centers of the world as well. So it's very important, and it needs step-by-step investigations, which Waqas has highlighted really, and it can be frustrating for the patient as well as the physician. So those who are investigating a patient of suspected Cushing's syndrome, be ready that it will take a bit of time to get to a conclusion, and it's not going to be an easy answer for you. Because if you do not spend enough time to investigate and get to an appropriate diagnosis, when you offer the treatment will not be successful and the patient's problem will persist. So, and especially when you are encountering a patient with pseudo-Cushing's, and you have not excluded it, then again, your treatment, as Waqas has told that 10% can be an incidentoloma in the pituitary gland as well. So, and as patients who have psychiatric manifestations or with obesity or with depression, which are causes for pseudo-Cushing's, it can sometimes lead to a failure of the treatment which you have offered to the patient. So it's very important that a steady approach should be adopted, and a patience is also required in the investigation of these cases. So that's what I have to say.
Thank you so much, sir. You're absolutely right that Cushing's algorithm can sometimes be too frustrating, and lots of patience is required to reach to any conclusion. Now I will request Dr. Aisha Sheikh to give her valuable comments and experience regarding Cushing's disease.
Thank you very much, Paris, and thank you, Dr. Waqas, for a wonderful presentation. And I can clearly recall those months and years of efforts that were put into bringing this pituitary adenoma guidelines, which are now available to all of our physicians across Pakistan at JPMA website. And through this series of webinars, which will be available on Pakistan Endocrine Society's YouTube channel as well. So you can even, it is like a repository, and you can refer back to it whenever you require. So as Professor Najam and Dr. Waqas have already highlighted the fact that Cushing's syndrome stays a challenging diagnosis. And it's always important that you look out for discriminatory features that Dr. Waqas was already informing you. Because if you do not look at discriminatory features of Cushing syndrome or features which are evolving, you might end up investigating people who are presenting with simple obesity. We know that obesity is very common right now, even in Pakistan. It's like around 40% of population is obese. But if you look at the prevalence of Cushing syndrome, that is not that high. Dr. Waqas has showed that it's like 3 people per million population can be having Cushing's, which means that you have to be on the lookout of features. So a detailed history examination is something that will help you identify discriminatory features. And then the other thing is to make sure that you are not missing an exogenous steroid intake. And that could be at times very subtle. The patient might be taking some topical uh, creams which are having steroids, or they had some intraarticular injections. So steroid administration through any route. So even inhaled, even rectal, even intraarticular, any route can actually lead to Cushing-White features. So until we are sure that this is not iatrogenic Cushing syndrome, we cannot proceed to investigating Cushing syndrome, endogenous Cushing syndrome. And remember that when someone is having iatrogenic Cushing syndrome, that patient actually will be having suppression of their hypothalamic pituitary adrenal axis suppression, and their workup and management would be totally different from somebody who is having endogenous Cushing syndrome. And when it comes to endogenous Cushing syndrome, unless you follow the sequence of investigations, that is important. Dr. Vakas has repeatedly highlighted that in his talk as well, that you have to first identify endogenous hypercortisolism through a series of tests, at least 2 tests that should be able to point towards the endogenous hypercortisolism. And then you proceed to whether this is second step, which is ACTH dependent or ACTH independent, and then you go on to imaging. The other thing is that since Cushing's is a challenging diagnosis, it's important that these patients are managed in settings which are tertiary care centers, have appropriate teams, multidisciplinary teams available to manage this condition. So make yourself aware that you have to refer these patients at some stage to expert centers. The other thing would be that the severity of Cushing syndrome would be different. So a person might be having a long-standing mild kind of Cushing syndrome, but then somebody might be having an ACTH dependent Cushing syndrome that is through an ectopic source, and that is a rapidly evolving Cushing syndrome. Over there, time matters. So you cannot delay their management a lot, because they will be at risk of thromboembolic episode, they will be at risk of cardiovascular complications and very high morbidity and mortality. And I'm sure in question and answer session, Dr. Vakas will tell us situations where you might need to offer a person adrenalectomy rather than looking for source. If the source is not available, how much time you can spend on investigating, because these are challenging cases and sometimes you might not be able to find the tumor. So remember, it's like being a detective when you are managing Cushing syndrome, but through an appropriate knowledge and multidisciplinary care. That is the key to success. So thank you very much.
Thank you so much, Dr. Aisha, for your valuable comments. And we have a couple of questions in our chat box. I would like Dr. Vakas to please address them. First question is how much dose of delta and duration can lead to Cushing syndrome?
Well, as Dr. Aisha mentioned, that any type of cortisol, it doesn't matter on the dose. We all the time see the patients, they say, okay, we are only using a cream for some skin lesion or for some other reasons. You'll be surprised people using the nasal spray for the nose or inhalers. They all can cause Cushing syndrome. So there is no dose which we can define that this can cause Cushing and this will not. But any cortisol, if there is a steroid, then they can cause the feature. Now, we are not saying it. If there is a clinically needed, you don't use it. Yes, they can be used if they are clinically needed for whatever reason they are used. But the main thing is we don't go into a trap where the patient got a Cushing syndrome or features because of that dose, and we start investigating them for endogenous Cushing. So you will see people say, oh, he's only on a small dose of prednisolone. We should investigate him or her for endogenous, or they end up doing MRI scan and things, and then you end up in a trap. So the important part is if they are on steroid, then you need to know about it, and you should not investigate them for endogenous Cushing if they are on any steroids.
Right. So next question is, how will I screen cause of obesity with only single test?
Well, obesity is, there is a whole session on obesity, or multiple session can be done. But what we are describing here is that obesity is a common thing, whereas Cushing is not common. And the important part is you have to investigate either that obesity. For example, if there is someone who come to you that I'm unable to lose weight, uh, that is different. But if there is someone who is coming to me and say that in 1 or 2 months, my weight increased for like 20 kg or 10 kg up, then that's maybe something which we will take as important to look for Cushing and things, but not for someone who got a high BMI for 20 years trying to lose for that weight, and there is no rapid. So it's the rapidity which might make us think of endocrine reason, which could be Cushing or something else. But chronic is not because of Cushing. It's a rapid change.
Right. So one more question we have, and that is, would the weight of the patient be relevant in ODST? Any ideas regarding higher dose for obese patients? Let's say more than 100 kilogram. So if patient is weighing higher, would there be a higher dose for ODST?
So this is a very relevant question. The problem with any test is every test got their own limitation, and that's why when we talk about which test to choose, then the patient parameters need to be considered. So, for example, that's why we say we don't only want a overnight dexamethasone suppression test. We want to, for that patient to have 24-hour urinary cortisol, which they will have 2 samples. Then we can choose another test. So weight and things, because the test can be positive in the test can be even positive with obesity, but we normally don't increase the dose. These are standards protocol for it. There are, like, if you go into the details of this, then there are multiple things. There will be talk about either we check the dexamethasone level and things, but those are something which are done in research and things. But as a general, we actually look at which test we are using, what is the pre-test probability, what are the test results are. Maybe you are not able to get the correct answer on the test. You might have to wait, as Dr. Najam said, might be we have to look back and maybe repeat the test over the period, but we don't change the dose. We don't change the protocols for the any test. I can't hear you. Paras, I can't hear you.
Okay. Am I audible now?
Yes.
Yes.
Thank you so much. So now we will compare pre-test and post-test results, and we will discuss then further. Okay, so for first question, majority have answered option number 3, pre-test, and post-test, it went to option number 4.
So I think they are the two different
Two
pre and
different
post.
options, yeah.
Yeah, they are different questions, na? They're
That's
not the
third.
same.
They're not the same. There is
Okay,
some
okay.
error somewhere.
Can we have comparison of same question, pre-test and post-test, please?
Yes. So
Okay, so
that's
this is
question
the
number 2.
question number 2, right? So in question number 2, before test, majority answered option number 3, that is 24-hour urinary cortisol. And post-test, again, the number increased and answered 24-hour urinary cortisol.
So I can say the answer they choose correctly, and this is the right answer, because as you mentioned, you have to confirm the evidence of endogenous hypercortisolism, and the answer will be, even if this case was more going toward adrenal, but still you have to confirm the endogenous Cushing. So this is the correct answer, 24-hour urinary cortisol.
Let me
Right,
add
so
here.
it was,
Yeah,
yeah.
let Dr. Najam want to add something.
Add here in endocrinology, this is the main thing is that we have to have a biochemical confirmation.
Yes.
Then we go for imaging. So if I remember correctly, the first question did not give any biochemical information about. So I think in the absence of a biochemical diagnosis, we cannot go for imaging. तो ये एक general principle है जो कि सबको पता होना चाहिए, those who are listening to this webinar.
Right, so this answer was endorsed further after presentation. Can we move to the next question, please? Okay, so in question number 3, majority have answered, picked option number 4, pre-test. And post-test also option number 4 is picked up the most.
May I answer this?
Yes, please.
So I think the answer of majority is wrong. As we mentioned, so if we can bring the question originally, so this was someone who is finding difficult to lose weight, and that weight is up for last 10 years. So the pre-test probability is quite poor. As we mentioned in that we need to have a strong clinical suspicion. So this patient was someone who got difficulty in losing weight, got some features, for example, the fat pad around the neck area and things. These are features which you can see in the Cushing as well, but these features can be seen in multiple other like a common like obesity and things. And as I mentioned in the answer is that we need to have a pre-test probability high. This one, what I remember, this patient was someone who is finding difficult to lose weight. There was no rapid weight gain or anything. So the answer was a low probability for Cushing. However, if we think that there is a strong probability, then yes, then we can do 24-hour urinary cortisol or overnight dexamethasone. But better to have a 24-hour urinary, but any of these tests can be done.
Very well explained. Thank you, Dr. Waqas. Now I will request Professor Najmul Islam to give his concluding remarks.
First of all, I would like to thank the Pakistan Endocrine Society for inviting me as an expert in this webinar. Second is I would like to first to thank Waqas for his presentation, which was very simple and to the level which most physicians watching the webinar would have understood. So I would like to congratulate him on this. And I think the presentation has to be close to what is written in the Pituitary guidelines. So it was like that. So congratulations, Waqas, for a nice presentation, a comprehensive presentation on this topic. And the third thing is that I would like to thank all those who participated in this webinar as well, because as I have told you, there's more. I hope most of those who are watching is the trainees, and this is a difficult topic, the Cushing's disease, not just for exam but also for in clinical practice. So I think I hope everybody has learned something from this talk, and they will apply that in their exams as well as in the clinical practice for the betterment of their patient. So thank you, Paras, for your conducting this webinar. And I think that's what I have to say, and I'll pass it on to Dr. Aisha for her final comments.
So thank you very much, all the audience who were here this afternoon. Professor Najam, for your guidance and support throughout the guidance development part, and your valuable presence in the webinars as well. We continue to learn from you. Thank you, Dr. Waqas, for an excellent presentation. That was wonderful. And thank you, Paras, for a wonderful moderation. And I'm really grateful to our IT support, Mr. Anas and Mr. Hatif and Mr. Harun Michael for their continuous support for all these webinars. Thank you very much.
Thank you so much, Dr. Aisha. I'm thankful to all of you for joining us this afternoon. Thank you, Dr. Waqas. Thank you, Sir Najmul Islam. Thank you to all the participants for joining us. Hope you had a good learning experience. It's time to say Khuda Hafiz, stay safe, take care. Allah
Thank you very
Hafiz.
much. Thank you,
Hafiz.
everyone.
Hafiz.
Hafiz.
Allah Hafiz.
Hafiz.
Hafiz.